Well, good morning, everybody, and thank you to the earlier speakers. It's been really interesting, and I know the speakers coming behind me, if you're like me, you're sitting there thinking, oh, I wish I'd written this, I wish I was about to say that, and why didn't I think about that? However, what I'm hearing feels something, as a recent patient, it still feels a very tall order, and it can feel a bit hopeless. How are we supposed to do all this when we're so busy? We've got so many staff, we've got so many patients coming in and out, and bed occupancy is 130% or something. It feels it's really hard. And when I read the Francis report, I think probably like everybody in this room, I felt so sad. Really sad, and I wish that I could put my hand up and say, oh, that wouldn't happen where I work, because I couldn't. And I think that very few of us could say that could never happen where we work. And we work in a system in the health service. I don't have experience of the private sector, but it's understaffed, underfunded, and all those things. And it felt to me with Francis, it was telling us a lot of stuff, but I didn't know, where do I start? Where do I actually start now to try and put this right? And so I did some more thinking about it. I come from an education, I'm a nurse, but education background. And all I can say, it was lovely when someone said, I love students, because students come in with a lot of this big C for compassion. And we do something to them on the way that seems to beat it out of them. And they end up cynical, jaded, cross with the world, feeling the world owes them a living. And so I started thinking, well, okay, so what can we actually do about that? And I feel that the 6 C's, excellent place, and I'm so glad that Jane Cummings has done this, really, because it's got us all talking about it. And we all know what it feels like, but it's pretty hard to measure, and it's pretty hard to even say quite what it is, but we know it when we see it. And my previous experience only last week of being looked after by a nurse practitioner in A&E, there was oodles of all of this. I felt absolutely confident. I didn't feel patronised. I felt looked after. I didn't even have to wait hours, which was marvellous, but it was all there. And interestingly, previous experience of healthcare as a nurse, I think we call people registered nurses too soon. I think at this level is really our nurse practitioner, where we don't expect it in medicine. We expect that to be consultant, and everything else is a training post to that point. Nurses, they finish, and on the next day they're accountable. Registered nurses expected to be able to cope. And when they don't cope, then I think quite a lot of this spirals from that. So my argument is that compassion is obviously what we want to aim for, and without, but if we don't have competence, then at best it's kindly concern, which you can expect from the public, and it's lovely. And when I did this and fell over, some lovely kindly concern from members of the public was very helpful. But that's not enough for professionals. It's got to be more than that. It's got to be at least that, I suppose, so maybe that's a starting point. So my feeling is that actually, if we get, where do we start? I would say, let's start with competence, because I believe that from competence, a lot of the other things can come. And why a lot of things go wrong in our general wards that we don't see, certainly once you get to specialist level, is because they're often young, inexperienced people who are scared, not quite sure what they're doing, and either being abrupt because they're scared, or they don't go near someone in case they ask them a question they don't know. And to me, it feels like if we can get competence right, maybe that will help. And so I do think it does fit in with the other speakers, because a lot of these skills we're talking about, and having courage, you have to know you're right before you can even challenge someone. Now, and getting an atmosphere where people, that Lorraine was talking about, where people can question, of course, all those things are important. But that too needs, still, you can't just be nice people having a nice time at work. you've got to be competent in order to be able to be a proper carer. And I think that being not feeling confident is one of the huge communication barriers. As anyone who's had to stand up and speak knows, if you're not confident about what you're saying, you end up reading it, or if you're just one page ahead of the students, you know, those awful sessions you've had to go in and do, and you just feel totally different, don't you? You can't sort of, so let's look at what we mean by competence, I suppose. Use the model, because I think this model for me is quite helpful. The origin of this is not quite agreed as to where it came from, but it seems to now be attributed to someone called Martin Broadwell, who spoke, and he wrote an article about teaching for learning in 1969. And it's saying how we go through these stages of our competence, and it's not really until we get to the unconscious competence that I think we can really start thinking about compassion. So the unconscious competence is, I don't know what I don't know. I'm unaware of the skill. I've never learnt this. I've never thought about it. And in order to learn, you have to bring people to the next level of conscious incompetence. And that's what teaching's all about, isn't it? Showing them what it is. And of course, this is where role modelling is so important. And I usually remind registered nurses and students that you can't, as somebody said, you don't decide I'm going to be horrible to someone today. But you also can't decide, look, I'm in a grump today, I don't want to be a role model. Because sadly you are. All professionals are role models all the time. And our students are watching your every move as a guidance and to know what it is they're trying to achieve. And so if that isn't good, because you're having a bad day, at least if you recognise that, you'll say to them, don't look at me today, don't come with me, or something. But it's very hard because you can't switch it off. So then you move into this conscious incompetent state. So you now know what it is you're trying to do, and you know that you need to learn it. And again, that's where role modelling is really important with those softer skills. It's easy when you're teaching them, as my background was all in clinical skills, teaching them injections, it was much easier to get their attention. Hold that needle, hold it like this, do this, stick that in now, imagine that's going into somebody. That was much easier than getting the soft skills and getting their attention. We all know how to talk to people. And in fact, I had a student say to me once after about 6 weeks in the course, well, I used to be able to talk to people before I came in, and now you've made it all so complicated that I don't feel I can. And of course, what he was grappling with is all the things you're doing while you're talking to somebody. Then the conscious competence, now you can do it, but you have to concentrate and you have to still think about it, and it's not yet second nature, or it's not yet become automatic to you. So you're still really having to think about what you're doing. And there's lots that we can all identify with those. And I remember I use driving as quite an analogy a lot, because I think it's quite a good analogy with nursing, which is my background, because if you get it wrong, you can kill somebody. And you have to concentrate. And I remember learning to drive. If someone says, do you want the radio? No, not while I'm turning right. You know, you can't drive and eat a sweet, or you certainly can't park. My next car is going to park itself, I've been told. But, you know, those sort of things when you're suddenly having to be conscious again, and that's when you need to focus on it. And you could probably demonstrate the skill now, so they demonstrate skills for us students, or whatever it is you're trying to do, for us to see that they can do it, but only continued practice. And this is where, forgive me, just one little hark back to the old days. I'm from education, and I will put my hand up and say I don't see anything wrong with task-focused care. And you can quote me on that, because what task-focused care, it's fantastic for training, because people have to do skills over and over. There are a few gifted individuals in the world who can just do everything. Almost everything we have to learn, and we only learn that through repetition. And so getting people to do it over and over again, and I haven't seen any, and if someone's got some, please pass it on, but I haven't seen any good evidence to say that patients found it terrible being treated well by 5 people instead of being treated possibly not very well by 1. And so often that person doesn't have all the skills that they need. And if you're with, I can't remember, but someone mentioned the nurse practitioner with the community, that having someone at the end of the phone who understands what you're going through and can help you in practical as well as emotional ways, to me, that is nursing. And that's when you see it at that level, that's real nursing. And on the way to that, people are still learning. So then we get to the 4th level, where now it's become second nature. I don't have to think anymore how to drive. I just watch out for cyclists. Any cyclists in this room? Watch out for cyclists, and I know what to pay attention to. And as novices, we pay attention equally, don't we, to the whole scene. As experts, we know what's important and what we can push back a bit. And now, crucially, now is when you can do this while you're doing something else. And of course, communication is such an important skill on its own, but usually, unless you're a counsellor, you're doing your communicating while you're doing something else. And unless you're really, really skilled at that something else, your focus is on the something else and not your communicating, which is what all novices are like. And so the care assistant who doesn't know what's going on or really doesn't know how to do something is only going to focus on that task and can't. And then later will maybe talk to you nicely. But of course that nowadays, there isn't the luxury of that. When I was training, they used to send me off to talk to people. And I could just go and talk to people. But now you're doing 3 tasks at the same time. And I say, I don't see anything wrong with that. We're never going to go back to those which were probably quite inefficient days. And I don't know if there was ever a great time for nursing. I don't know if it ever was fabulous, as it is in my mind. I don't know if it ever was. Maybe it was always like this. The difference, I think, was that the people who were untrained nurses were on the way to being trained, instead of care assistants who get a very different training wherever you are, and wonderful people. And we've got, that's a fact. Somebody said we've got to get on with it now. That's a fact. That's the world we're working in. And so therefore we need to make sure they are competent. Because I think most patients, if it's not ideal, would settle for efficient without a smile, rather than smile without an efficiency. You know, so it's no good holding my hand while I bleed to death. I'll feel better about dying, I suppose. But, you know, it's got to be the 2 of them. It's got to be the 2. So I was starting to think about how do we get to this competence and compassion. And it made me think back to Maslow's hierarchy of needs, where he was very clear, and I think we can see lots of examples of how this is right. Unless you get the basic needs, then you can't worry about safety needs. Unless you get safety needs, you can't worry about social needs. And we see this where communities disintegrate, where those basic needs are not being met because all the others are not achievable. So I was thinking, well, maybe then there's something about compassion in practice that we've got to start off. And we've talked, and Francis and Cavendish have talked about selecting nurses. Extraordinarily difficult, any of you who are involved in selection, because there's such a range of roles for nurses. I've always said, actually, we'll find a place for you. Because you may be working in a special care baby unit, a hospice, an operating theatre, a daycare. It's such a range, and you probably need slightly different skills and attitudes for each of those. So I think we can probably fit most people in, as long as they want to care. They need the right knowledge. Of course they need the right knowledge. I'm not sure when is the right time to get the knowledge. I think I'm quite a concrete person. I like to get on with it, do it, and then find out what I need to know, maybe. So we tend to preload a lot, get all this knowledge, and then go out and apply it. And what we don't spend as much time on, I think, is helping them apply it. And that's where it gets lost, where they can't see quite where that knowledge fits. We need the right competence, so the knowledge needs to be there in order to be competent, because again, you might better do something by rote, and again, I don't think that matters too much depending on your level. If you can just do it without really necessarily understanding everything. Otherwise, I was a terrible nurse for many, many years because lots of things, windows opened much later. Oh, I see. That's why I did that. But I did it well. But only later I was much, much more knowledgeable. And of course it gets much more scary then, doesn't it? I think ignorance is bliss is never more true than in nursing, isn't it? And, oops, going the wrong way, sorry. And then I think if you get those in place, then compassion maybe will just happen. Because if you've got the right people who actually want to care, although having said that, you know, it is the hardest job in the world, isn't it? It really is hard to keep that 24/7 compassion. And I often talk to students about waiters and waitresses in Italian restaurants. Italian restaurants take the smallest space possible, get as many tables in, they work lousy hours for not very good pay, which is usually nurses say, oh, that's us. And yet they're always charming and smiling at you. And so what do they get right? Now, I suppose people are in a different mood when they're there and people are out enjoying themselves, but they are often up against it. They've got people who've had too much to drink. They've got people who won't get out of the way, who want to take photographs when they're trying to bring out their trays, and yet they're smiling at you. And don't you feel looked after? Doesn't matter what the bill is. And then you say, oh, a bit more on that. 12.5% nowadays seems to be standard. Give them a bit more. They were so nice. And yet it's harder, I know it's harder in nursing, but it must be somehow coming from here. It must be coming from there. But underpinning that is not feeling scared, because I think we run away if we're scared. And if I know what I'm doing, I think it's easier. And certainly when you go in as a lecturer, it's marvellous, because you go into a busy ward, you take a student with you, and they basically, the staff just leave you with a difficult patient and you get on with it. But you notice that you're not scared of anything, and you can help that student. You have a go. Watching someone do something is one of the hardest things in the world, isn't it? Because are they going to get it right? Oops, sorry. Left-handed. So, if competence is where we need to start, I would argue, so that all of our nurses are starting at whatever level they are and try to get them able to act to the level they want to be. So how do we now try and get all these ducks in a row to try and end up with compassionate care? Well, one of the things I've been working with is Nurse Excel, which is conference is hosted by today, because it feels to me that if we can make knowing people are competent and allowing them to know and recognise that they're competent, because the code of conduct is marvellous. We got up to number 42 in that, which is nearly on the scale of Francis of the things we've got to all do. And when I first started working with Nurse Excel, one of my questions was, well, how do I know what I don't know? So how do I know if I'm competent? How do I know if I'm up to date? And I'm just slogging through the day and getting through. And so that's why I started working with Nurse Excel, because what we wanted to come up with was something that makes it easier for managers and supervisors to know that their staff are competent, but also to make it easier for staff to check themselves out. It's hard, I think, Clive, you asked, how many would be happy to be a whistleblower? Well, I wasn't even sure if I want to put my hand up. That's being brave enough, never mind whistleblowing, and trying to answer a question or say, excuse me, and students will still say, this is a really stupid question, but you know it's only the confident ones who are even asking that question, don't you? The unconfident students are sitting there and lots of things that they're just missing out on it. And my other theory is, well, if you've got students, the student always gets grabbed for extra attention, is the bright-eyed, bushy-tailed, oh, come on, you'll love to see this. And actually the one we really need to be working on is the one who's more reticent, a bit more scared, etc. So what we were trying to do with Nurse Excel is to come up with a way of enabling staff and students as well, it will be, to check their competence level. But for supervisors, if you do some sort of knowledge test online, then the supervisor doesn't have to worry about testing all the underlying knowledge. They can focus on how they're doing. And from a manager's point of view, you don't need to worry so much about whether your supervisors, what they're like. We all know, don't we? One day you did a test and you got an absolute grilling from someone, and then your friend says, oh no, they just said, show me how you do it, and tick me off. So you know you standardized what that underpinning knowledge should be by making sure and allowing students to work in their own pace at their own time. And students for whom English is not their first language, it can be quite daunting. And I saw an evaluation from a student, luckily it wasn't in my session, but he said, well, it may as well all have been in Greek to me, because there was a lot of technical language. And it, you know, nursing is technical, but he lost it at the beginning. Whereas if he was doing that himself online, he would have gone to look that up, found out what it was actually about before he carried on, because he didn't understand something. And in the big lecture theatres, it's jolly hard, isn't it? And all our students now are in groups of hundreds of them. That was better in my day. I think I had 14 in my set. Those were the days. So that's what Nurse Excel's trying to do, and to produce for the managers a dashboard, the language of management now, isn't it? You've got to have a dashboard, but a dashboard that will allow you to see what your staff have done. Because what we found as we're talking to hospitals is that people are doing huge amounts of training, but when the CQC say, what have your staff done? There may be a scrabble amongst all that heap of papers, but nobody actually knows. It's not just there at the touch of a button to say, well, 78% are up to date with whatever they need, etc. And so that's what I felt was worth working on, because it felt like, where do we start? Let's start with competence, and here may be something to help. Thank you very much.